it is only the metastasis positive. For HPV negative, in HPV negative, there are not much changes. It's almost like if we know the oral cavity staging, it's almost the same. Just that T0 is removed, and then the classification also it's almost the same. In clinical part, ENE is only if it is there, it is to N3B, and in the pathological, it is N2A and N3B both. M classification is unchanged. Overall staging is also almost unchanged, just that ENE is included as in the oral cavity. So I think I can skip a part of it. The P16, it's almost the similar one. The nodal staging again the similar one as the oral cavity, where it is N2A. The clinical stage in the clinical staging, ENE positive is just making it N3B. That's it. Otherwise same. But in pathological staging, if I go, the N2A is also involving a single ipsilateral less than 3 centimeter. ENE positive will make it N2, and anything more than that will directly make it to N3P. And overall staging also for this P negative has not been changed. But there is a drastic change in this P16 one. I've already told that in this, it is only the T4 is now only till T4A. T4B has been removed. In clinical lymph nodes, it is unilateral less than 6 centimeter, contralateral or bilateral less than 6 centimeter, and if it is more than 6 centimeter, it is N3 directly. And for pathological, it's even more simple. X and N0 we know, N1 is less than 4 lymph nodes, N2 is more than 4 lymph nodes. That's it. And this staging has also been changed. As I told earlier, that M1 is now stage 4, and there is a down staging of the T staging also in the overall staging. So as such, if we broadly discuss, I'll discuss it like in this detail, but just for a broad discussion, like if it is stage 1 to 2 oropharyngeal carcinoma, we have two entities like positive and negative. For positive tumors, we have got a single modality treatment. We can either go for RT, we can either go for primary surgery. Lots of trials are there which have told that both are good. And for HPV negative, again, we have got modality, single modality is possible, but there we'll go for primary surgery more, and then later on CTRT according to the adverse features. And if it is a resectable tumor, but high stage T3T4, but resectable one, I'm talking about, then in case of HPV positive, the Bozek et al. Has told that it's even if it is resectable, but HPV positive tumors are better, as we have seen the thing that the P53 gene can be reactivated with CTRT and all. So for good overall swallowing and other results, we can go for CTRT rather than going for primary surgery in HPV positive ones. But HPV negative, it's better to go for primary surgery because they have got poor prognosis. So these are the NCC guidelines. I think not much has been discussed in it. They have given all the options. I'll just quickly tell the workup. All of us know the workup. Just to sum up, I'll tell the workup. We have seen that we can go for HPV testing. We can go for the whole head and neck examination. We can go for as they present with nodal masses usually. So we can go for FNA, we can go for either MRI or CT scan. There is some role of PET-CT also. Usually in those cases when like in tonsil primary, it goes no. There like PET-CT also has a big role. And then all those other like nutrition, speech, swallowing, and smoking and counseling and all, we have to do it now. So if P16, we have seen that if it is negative one, if it is negative, we have already seen that the broad spectrum I told. So the first option we should opt for is, although we have got option of resection, we have got of RT and the clinical trials, but the first option in negative, we would go for the resection and the bilateral or unilateral neck dissection, followed by RT. And in T3, 4A, N0 tumors, then we will opt for concurrent, and second option we will go for resection. And in even higher stages, again, the same thing will be repeated, almost same, but one new thing is now coming because it is even higher stage. So we can opt for induction chemotherapy also, right? And later on, we can go for, after induction, we can go for CTRT. But for HPV positive tumors, like if it is very small, then it's easily resectable. We can go for the resection, and second option is RT for us. But if there is a nodal disease, again, if it is, but if the node is single and it is, better go for resection and then opt for RT, right? But if the is more than 3 centimeter, then it's always for HPV positive tumors. We know the primary as well as if for the nodal disease, for functional good outcomes, we should better go for CTRT, and then second option should be the resection. Right. Same. It is even high HPV tumor. And for high stage like risk factor tumors will be concurrent CTRT as the first choice and the resection is the second choice. So like we know what is happening. We have got radiation therapy, we have got chemotherapy, we have got surgical techniques. Earlier it was pharyngotomies and mandibulotomy. Nowadays we have got transoral robotic surgery and transoral laser microsurgery. So we know that now. This also we know like how in low stage and high stage tumors we are dividing it. But and chemotherapy also we have got very good. We have got cisplatin and now TPF and cetuximab also has been rising. But the problem with this chemotherapy is this. There is some level of acute toxicity, and more than that, it is a chronic or late toxicity. And this is the reason why we are now trying to shift our protocols from CTRT to surgery, because we have got better options. We have got laser surgeries. We have got the transoral robotic surgeries also. So this we have come because of these things. Now we are trying to opt for this. So these are few of the trials which have been done for transoral robotic surgeries. So very good results, like overall survival from something about 82% to 100%. Winston et al. Shows 100%, but there is a catch. I'll show in the next slide why like there's a catch in this 100%. But anyways, we have got 82% to 100%, and in the local region 91% to 96%. So there are very good results with the transoral robotic surgeries we are getting. So these are these same trials, but in a bit detail. So that I was telling, like, I'll tell you why the 100% overall survival is a catch. Is that only 30 patients were there in the Winston et al. But in other trials where it is 204 or 364 patients, see, the overall survival is getting reduced. So this is the actual, the 100% is not the actual thing which we are seeing. This is the actual data which we are seeing. But still it is like promising. If we are getting 87% good results of overall survival and 88% of local regional control with the TORS group. This is the Situ loading 400 and 250 local, followed by 250. Almost similar outcome, but problem is that few studies showed that it is similar outcome. I'll show some trials where the cisplatin and cetuximab is being compared and what has happened there. So although it is again a promising thing, but still we are on the like trial basis for cetuximab right now. So like if I talk about a pre-TORS era, in fact I should say even pre the surgery was in the surgeries, because this is the data from 2000. At that moment, if we about the 90s, we had got a VA trial, we have got GOTEC trial, which gave us beautiful results in larynx and oropharynx. So, but earlier than that, surgery was the main choice. But the problem with the surgery was it was a bit morbid surgery. So this Parsons et al. Did a beautiful trial comparing this surgery with the evolving radiotherapy. So they divided into surgery with and without radiotherapy and radiotherapy with and without neck dissection. And it acted as a benchmark for evidence-based counseling of the patients of the oropharyngeal carcinoma. Why? Because both of these groups had similar results for local control, loco-regional control 5-year results. But the problem was that because the surgeries were morbid, were severe, or even some fatal complications occurring with the surgery and the radiotherapy group. So authors concluded that the radiotherapy is, although the thing is that at least we had like an option, like if we opt for surgery, we can still have a better surgery, less morbid control. So next was a trial Angatol. I think I'm fourth time I'm talking about this trial, a beautiful trial, RTOG 0129, the same trial, the RTOG 0129, which I told. And this was the landmark trial, which actually told us that HPV positive has got better results than, better prognosis, than the HPV negative tumors. A total of 63.8% of patients with oropharyngeal had HPV positive tumors with better 3-year survival. Then there was a trial, RTOG 1016, where we started thinking about de-escalation. Now we know that we have got few options. We have got radiotherapy, we have got chemotherapy, we have got surgery. And like as we saw in smaller stages and higher stages, what we are, these things can be changed because we have got promising results with everything. We have got promising results with we were getting promising results with cetuximab. We were getting promising results with oral, transoral robotic surgeries. So they tried to compare at least cetuximab with cisplatin, because cisplatin has got some toxicities. We all of us know it is renal toxic and lots of other toxicities. So they tried, okay, let's try if we can replace cisplatin with cetuximab, and it was a very big trial. It was in 182 healthcare centers in USA and Canada, right? And all the patients after this, they got IMRT. But after 4.5 years of follow-up, the trial told us that cetuximab did not meet the non-inferiority criteria for the oral radiotherapy plus showed survival. This is only one trial. We have more than 3 to 4 trials done at the same time. You know, all of the trials, the cetuximab has failed to show the positive results. One trial which initial days pointed, okay, yes, de-acceleration can be difficult, but then other trials came. So then it was like, okay, we have got promising results with transoral surgeries. So why not do transoral surgeries and then reduce the radiation therapy, right? So then, as we know, that CRT is obviously curative, but it induces toxicity. So let's reduce the dose of the postoperative radiation and reduce the toxicity. So they reduce the dose to 50 gray. 70 grays, we know standard dose we are giving. In this trial, they decreased it to as low as 50 gray, and they had 4 groups. One had 50 gray, 60 gray, and 66 gray, and it has got promising results. Outstanding oncological outcome and favorable functional outcomes came with primary surgery with a reduced postoperative radiotherapy. So this trial showed us some hopes. Yes, we can de-escalate at least in HPV positive patients. Then again, quarterback trials came, and then 2 de-escalate trials came. But this was again a very beautiful work done by Marshall et al. They gave us the summarization of all the 4. They summarized the results of 2 quarterback trials, and also in discussion they discussed it along with de-escalation trials also. In this, what they did was they gave induction chemotherapy. Right. So in chemotherapy, we had seen in higher stages, we had one option of induction chemo also. So they give induction chemotherapy and reduce the dose of CTRT later on, which is what we were intending to do. And this also had promising results with TPF induction chemotherapy in high-risk features, followed by reduced CTRT, loco-regional and overall survival was very good, and treatment was tolerable, and even the toxicity was manageable. And they even told that these trials have got even better results than the two de-escalation trials also. So this also was again a promising results where we could reduce the CTRT. Earlier we reduced it in TORS group with TORS, and here we are reducing it after the induction chemo. Now, as we are talking TORS, so there are another important trials. There are actually lots of trials, but two trials are to be mentioned that told us that okay, let's now straightforward compare radiotherapy with neck dissection. Earlier it was a combination type, right? Through one group radiation and one group getting transoral, but with neck dissection. So there were like a few adverse effects coming. In radiotherapy group, it was dysphagia, hearing loss, and mucositis, while in TORS plus neck dissection, it was dysphagia and one that caused by the bleeding. Anyways, so the good thing was although it was showing that radiotherapy is superior in swallowing related results after 1 year, but when it was the overpolated in next 2 or 3 years, the overall difference got reduced, which again showed positive things. Although this trial had told that the radiotherapy group was better, but by 3 years we got to know no, the TORS also has got good promising results in long term. And then again, the TORS group, the Orator trial got another trial, okay, because they got some promising results. So they thought, okay, let's do Orator 2. So there they got primary RT with cisplatin and TORS with neck dissection with a reduced RT, right? So this is again what we needed. We needed a reduced RT. Reduced in group with earlier also we had seen like TOS with reduced RT. Here also then again tried, okay, let's keep that as a control group and reduce the RT in the 3 group. And in both the arms, they achieved good swallowing outcomes and at 1 year. That was very good. But the problem with this trial was that it was associated with some unacceptable risks of grade 5 toxicities. In fact, there were 2 deaths. So this Orator trial had to be stopped prematurely. But anyways, it gave us some hope about like, yes, we have got a future ahead where we can de-escalate the things. But it's all about de-escalation and all. Best thing possible is what? Best thing is always prevention. So as we have already discussed, sir, this is what is going to be our future rather than going for the trials and all. If we can have this thing, we can even prevent the disease, forget about treating it. And this also, sir, as you told us, there are 2 doses, like different types of vaccines. There are bivalent vaccines, there are quadrivalent vaccines. For 9 to 14 years, we have got 2 doses at 0 and 6 months, and for 15 to 45 years, we have to add one. After 15 years, we have to add 1 dose. For bivalent, it is at 1 month, and for quadrivalent, we have to add it at 2 months. But the thing is, again, HPV vaccination is only preventing the new incoming vaccines, but infections, but ongoing treatment has to be the same. So I think with all this discussion and all about HPV positive, like de-escalation and all, at least we know that this incidence is increasing and it is going to increase. So best thing is like, as I told that finance minister has told that for the girls 9 to 14 years, HPV vaccine is coming. But I think the future is gender neutral prophylactic HPV, not only the girls. And the treatment intensification, if we are talking about, yes, there are lots of challenges. As we know that those we are keeping in the trials, they can have recurrent disease. So that is again a challenge. So we have to take that with a pinch of salt and go ahead with that. And I think I'll end with this, with like, if we can prevent it, March 4th is the HPV awareness day. Let's aware people about HPV. Let's have vaccines and screen more and try to prevent this havoc rather than more about treating it. That's it, sir. Thank you very much.
Okay, Dr. Amonka, nice presentation. Any question? Hello.
think either everything is clear or nothing is clear.
No, it was a wonderful presentation, Dr. Munga. Very nice.
Thank you, ma'am. Thank you very much.
So there is a question for Surbhi. Surbhi, like as Dr. Monga has discussed about various trials, phase 1, phase 2, phase 3. So what do you mean by like these phases of trial? What is phase 1 trial? What is phase 2 and what is phase 3? Any idea? Rizul? Yeah.
We take patients healthy patients.
Yeah, I think there is some network issue. So
Yes, sir.
if there are no questions, then okay. Suti madam, Vinay sir, anyone, any comment?
It was nice. Very well covered.
Thank you, ma'am. Thank you.
Okay.
Okay, so I think then we can stop. Many things to be discussed. So this is for Rizal. Just read about these trials, no? Phase 0, phase 1, phase 2.
I think she is.
Kunal sir, for examinations, sir, and in them we check efficacy and safety of drugs, sir, for level 1, sir, and level 2. So we take around 100 to 200 patients, and then in them we see the pharmacokinetic and pharmacodynamic of the patient of the drug, sir. And
then phase 3? Yes.
Phase 3, sir, we take more number of patients, sir, and in them we check the drugs, doses and efficacy of the patient, and then in part 4 we do post marketing surveillance.
No, in phase 3, what I know, I don't know. It is compared that whether this present treatment is better than what it is existing in the market, or like those things is to be discussed to see whatever the protocol what we have made, whether that is going to give us the resultant result or to see. So okay, we also don't have much knowledge, so just go through it.
Compare with already standard drug is there, na? So we will compare how much is the efficacy for that drug. In phase 3, we will see on larger population and long-term complications.
Long-term complications.
And nice presentation.
So the last question, like how do you follow up such patients? Once the patient has got his treatment, so how do you follow such patients? How do you see that such patient is I want to ask, what is the prognostic factor? How do you prognosticate such patients?
So actually, the prognosis again is there is not much change in the prognosis.
So any marker for that?
Yes, sir.
Any marker for that? We can use it to see the treatment response, whether the chemotherapy check the circulating viral DNA, that is known as ctDNA.
Okay, so that is P16 and all HPV DNA. Okay, sir.
DNA is that will give an idea, no? The same goes with your nasopharyngeal carcinoma as well.
Yes, sir.
Positive cases. So what I see that can also help.
Okay, sir.
So nice presentation. Okay, so here then we end, and the next presentation is by Dr. Rizul. Am I right?
Yes,
all about CT, MRI, PET, everything.
Yes, the very basics in head and neck, sir.
Okay, so we will discuss what to present, because radiology is a very vast, very specific what. Okay, take care. You are